Welcome to Westmead Private Hospital Virtual GP Education Program. Today we are joined by Dr. Manish Gupta, an orthopaedic surgeon specialising in upper limb. Today, Manish will be discussing with us how to manage common shoulder and elbow conditions.
The brief was to talk about some shoulder and elbow, particularly as it refers to general practice. I do like what the College of General Practice has done with regards to GP teaching. It's not all about specialists getting up to boast why they're the best. It's about something that's practical for you to apply in practice. Okay, so I'm going to do it in cases. And they're kind of illustrative cases. They're not real, but they're cases that I do see a lot of when people come to me as a specialist, and I think I can feed that back to GPs as something instructive. So the first case is a 50-year-old female who presents with a 3-month history of shoulder pain. No real history of injury or anything like that. She does have pain at rest when she's sleeping and with most activities. She's talking about difficulty sleeping, as we mentioned. She can't reach overhead. She can't reach behind her back. She's finding it getting more and more restrictive. Her only significant medical history is a history of well-controlled type 2 diabetes. So she duly gets sent for an ultrasound, and the ultrasound report, everyone has seen an ultrasound report like this. Supraspinatus tendinosis without tear, mild subacromial bursitis, may be amenable to an ultrasound-guided injection, clinical correlation recommended. That last line I love because it's radiologists sounding a bit funny because we are clinically correlating everything we do. But anyway, that's the way they talk. So the thought process that goes on, well, this lady's got a painful shoulder. I've sent her for an ultrasound which says there's subacromial bursitis, and that bursitis must be the cause of the pain. They've also suggested an injection might help. So let's do an injection. 1 month later, you review the lady, no improvement. The injection didn't do anything. It hurts just as much. And I'm really struggling to move my arm. And then the well-meaning GP says, well, I don't know, this will probably need an MRI. I can't really refer for an MRI unless it costs the patient a bucket load. I'll send it to Dr. Gupta. He can review and he can organize an MRI if he thinks appropriate. Fair enough. So I see the patient in my office, and then I do a physical examination, and this is what the salient features of my physical exam are. That her shoulders are symmetric, that her active motion, she's able to elevate the arm in the forward plane up to shoulder height, but she really arches her back and hitches the shoulder blade to get there. So it's not a normal, natural movement. You can see the struggle on her face. When you ask her to laterally raise the arm, again, she hitches the shoulder and she gets it up, not even to shoulder height. And when I asked her to externally rotate the arm, she can only achieve 10 degrees, where the other side she achieves a normal 80 degrees. Then I stabilize the scapula and perform a passive glenohumeral movement. So if I stabilize the scapula, I can isolate movement in the glenohumeral joint. So I just put one hand on top of the scapula just to hold it tight, and then I perform a passive motion of the arm. And I note her abduction is limited to 30 degrees and her external rotation, just with her active motion, is limited to 10 degrees. Because of the limitation in movement, it was difficult to really test strength to isolate various muscles. And I noticed that within whatever motion she had, there was no real crepitus. So, 50-year-old lady, painful shoulder, insidious onset. The differentials, it's quite simple. If the passive motion is reduced, as it is in this case, then the differentials really are adhesive capsulitis or some form of arthritis. If the passive motion was normal, in other words, she may be actively unable to elevate her arm or reach away from her body, but passively you can lift her arm up, you can externally rotate the arm, then things like subacromial impingement, bursitis, rotator cuff tears become an option. So as I said, in this case, passive motion is reduced. So bursitis can't be the cause, and that's why an injection into the bursa failed to provide the relief she's looking for. So the differentials are glenohumeral arthritis, which in a 50-year-old without any significant history is unlikely, or adhesive capsulitis, which is more commonly known as frozen shoulder. So what test is going to differentiate? This is one I usually throw to the audience, but you're all very intelligent people and you know very well the test that's going to differentiate between a capsulitis problem or a joint problem like arthritis is an X-ray. And here we are looking at a set of normal X-rays. There is no arthritis on this. On the left-hand side, we have an AP view of the shoulder, which looks normal. In the middle, we have the axillary view, which shows the joint space very well and shows that the joint is in good position. And on the right side, we've got the traditional scapular lateral view, which again shows no significant problems. To the astute eye, you might notice that the anterior aspect of the acromion does have a minor little hook to it, which may predispose to impingement, but that's not the primary cause again. So here's one of the slides I referred to earlier, which is a busy slide that says a lot of stuff that you're not going to read through. But the key point is we've got a 50-year-old lady with a painful shoulder of insidious onset. And if we looked at the history, we're not really able to determine necessarily which one it is, but a simple physical exam, which is what's highlighted, shows that a global reduction in active and passive motion is more likely to be adhesive capsulitis or arthritis, but the X-ray is normal. And in the examination of impingement, you would notice that they're still able to elevate the arm and certainly passively are able to elevate the arm, but they may have positive impingement signs and the so-called painful arc. So that's a good discriminator here. The learning points here are that history doesn't need to be complicated, quite simple as the patient tells you, but a simple physical exam, just looking at active and passive motion, will really give you a lot of information regarding what the diagnosis is. A lot of well-meaning and time-poor primary care physicians send people immediately for an ultrasound, but in isolation, an ultrasound is a poor diagnostic tool for shoulder complaints. There are a couple of reasons for this. One, it doesn't have the penetration of the glenohumeral joint. Two, it doesn't show the bones and the joint surfaces very well at all. And three, almost everyone over 40 years old will have some subacromial bursitis on an ultrasound, but that doesn't mean that's the cause of their symptoms. So be wary of getting an ultrasound and acting on that in isolation. Always perform your physical examination first and always perform an X-ray first. It's always the best initial investigation after a good history and examination. I was a registrar once to a very respected old orthopedic surgeon who was once president of the AOA, who said to me that the orthopedic physical examination should be look, feel, move, X-ray, irrespective of what the complaint is. Even if you think it's soft tissue, an X-ray will give you lots of information. In this specific case, the X-ray would have differentiated between arthritis as a cause of painful loss of motion versus capsulitis as a cause of painful loss of motion. Any questions at this point in time?
No, Manish, no questions. If anyone has any questions, please type them in the chat.
Okay, good. And the other thing is advanced imaging is not required. You do a simple history, a basic physical exam looking at active and passive motion, get an X-ray to make sure there's nothing sinister or arthritic. Advanced imaging is not required here. So the diagnosis here is frozen shoulder. I'm not really going to spend some time talking about the management of frozen shoulder. Well, I can talk very briefly, but I don't want to, I've got a lot of slides to get through, but essentially frozen shoulder goes in a synovitic phase, which is painful with progressive loss of motion. The synovitic phase is replaced by the fibrotic phase where pain settles down because there's no inflammation, but there's fibrosis which causes stiffness. And then you get a resolution phase where the fibrosis settles and movement is recovered. It has a self-limiting natural history which can be protracted. In the synovitic phase, corticosteroid injections are useful. In the fibrotic phase, there's not a lot that's useful other than surgery if needed. But knowing that the natural history is benign, you just wait in most cases. The second case, the 72-year-old man attends your office. He presents with a 1.5 year history of pain and progressive weakness in his shoulder. He does enjoy, he used to be a builder and he's retired, but he continues to enjoy a little bit of work around the house, and he gets pain, especially when he reaches overhead, reaches to his backside, and he has difficulty sleeping at night because of pain. This time we get a physical exam because we're not going to be fooled this time. We're going to actually look at the patient, do a physical, which I'm sure you do, but I'm just trying to fine tune that. Have a look at the patient. You notice on the left shoulder, there's a minor wasting of the supraspinatus fossa, and that's noted as a prominence of the scapular spine, which you can see running horizontally across the shoulder at the left side. On the right side, it's well padded with muscle. This patient finds it difficult to elevate the arm, but he can do it, but he does hitch the scapula. He finds it painful and it's weak, but you're able to elevate his arm passively, but he does get some impingement pain when you lift his arm up. This patient was seen by one of your colleagues in the practice who sent the patient for an ultrasound thinking this is going to give me the answers. And here's a report you've all seen again. Supraspinatus tendon tear with retraction, subacromial bursitis, may be amenable to an ultrasound guided injection. Clinical correlation is recommended. You're not going to be fooled this time. You shelve the injection in the first instance and you think, you know what? I've got a guy who's got some protected or preserved passive motion, but who's got some weakness and pain with active motion. I'm going to have a look at an X-ray. And here's the X-ray. In the X-ray, the radiology report here is right. The reason I know that is because I wrote the radiology report. But it says superior migration of the humeral head, consistent with full thickness tear of the supraspinatus. There are signs of arthritis here with loss of joint space and subchondral sclerosis. But the part I put in the radiologist's mouth was, may benefit from a CT-guided injection for pain relief. Clinical correlation is recommended. But you look at that X-ray and you think, wow, that doesn't look like a simple rotator cuff tear. That looks like that's a rotator cuff tear that has been going on for a while and has now developed into an arthritis problem. What do I do with this person? And you know that Dr. Gupta's standing in the background with a knife in hand, ready to operate. And you're confused. What am I going to do here? So here's an algorithm that it's a simple algorithm, but this is an algorithm I use to treat rotator cuff disease. So the commonest group of people are the group one, so-called group one. They're chronic, degenerative, generally atraumatic, no trauma, full thickness tears, and they tend to be an older age group. They're often irreparable, but not necessarily. But nonetheless, in a chronic, degenerative, old rotator cuff tear in an older age group, and that greater than 60, I think this is an old slide, and I would shift that greater than 70. 70 is the new 60. Similarly, I'm approaching 50, but 50 is the new 40. So chronic full thickness tears, older age group, a more degenerative wear and tear type phenomenon. For the reasons I'm going to outline in a moment, they're best treated with conservative therapy in the first instance. Conservative therapy will be injections, so you can follow the radiologist's advice on that one. Conservative therapy will be oral analgesics and anti-inflammatories as appropriate. Conservative therapy will be physical therapy with a goal mainly on functional rehabilitation. And the reason for initial conservative therapy in this group is essentially twofold. One, they achieve the desired goal of resolution of pain and restoration of useful function with this simple measure without proceeding to surgery. And two, surgical repair of rotator cuff tendons in this group is often complicated by failure of the repair. So, because it's a chronic degenerative problem. So That's why, two reasons. One, they usually get a good outcome just with non-operative treatment, which is why we should try non-operative treatment. And two, operative treatment may fail anyway if it's rotator cuff tendon repair. That's why this group is often recommended shoulder arthroplasty or reverse shoulder replacement if they come to surgery. Group 2, now group 1 is the biggest group by and large. And unfortunately, because group 1 is the biggest group, there's this common misconception that all rotator cuff disease should be managed non-operatively and none of it will benefit from surgery, and bad luck, you know, it is what it is, go away, go to a physio. But there are a group of people that will benefit from surgery. Acute tears. Now, acute tears doesn't necessarily mean traumatic. Acute tears means where the symptoms have occurred acutely. So one day I'm at work and I'm okay. The next day I wasn't doing anything that I don't normally do. Someone drew on my slide. Someone's drawing on my slide. But group 2, where the symptoms are acute. I'm at work or I was just doing what I normally do and suddenly I'm developing symptoms. And so all acute tears, which are full thickness, more than 10 millimeters, or even chronic tears in younger, and that's physiologically younger people, people who are more active, people whose either occupational or lifestyle needs are higher, they do benefit from early surgical repair as long as the tendons are surgically repairable reliably, which means an MRI scan will be needed. That's something I'm happy to take care of. What I ask the referring GPs is not to just cast them into the group 1 bucket and say, well, we'll send you to physio for 6 months, a surgeon can't help you. If the symptoms are acute or the patient is physiologically young, do consider surgical referral. And group 3 is the even younger group, but they're the ones with tendinopathy, partial thickness tears, subacromial bursitis, or really small full thickness tears. They can recover and heal with conservative therapy. So definitely send them to your friendly physiotherapist, consider injection therapy for pain relief, and just monitor their progress. So the summary here is, well, let's talk about another case. This is a different patient, also 70 years old, no real arthritis. You can see at the undersurface of the acromion, there's significant sclerosis, that eyebrow over the humeral head. And the greater tuberosity, the bump where the rotator cuff attaches, there's some sclerosis and cyst formation here. This person presents with a short history of an inability to elevate the arm. He's retired, he's probably 70 years old, but he was fit and well until he was doing nothing out of the ordinary in his backyard, and suddenly he's got painful weakness of his shoulder. I'm hoping this video will play. I hope the audio is not playing, but we see this guy. That's not me, by the way. This is just a video I pulled from YouTube. We say, oh, look, I can lift his arm up, no problems, but I'm going to ask him to control his arm. Whoa. He's got no control of that arm where supraspinatus needs to work. He's got a weakness, but he's got full passive motion. And the previous person also had reasonable passive motion despite the development of arthritis, but significant weakness. I won't labor this slide, but again, we do notice the difference between passive and active motion. So if all you do is assess what can the patient do themselves and what can I do for them, it'll help you make a diagnosis. The learning points here are, now, I don't know if anyone remembers the old Castrol motor oil television ads, but I love old ads because the jingles and slogans were so much better, and no one watches ads anymore because you can fast forward. But the old Castrol ads were oils ain't oils. So similarly, rotator cuff tears ain't rotator cuff tears. Don't lump them all into one basket. Look at your patient, look at their lifestyle needs, look at their duration of symptoms, look at the difference between active and passive motion. Based on that, you'll be able to determine this person will probably benefit from physical therapy and injections and might not necessarily benefit from surgery, or this person's symptoms are acute, their needs are higher, their needs are more, I might consider surgical referral. And again, other than an X-ray, advanced imaging is not required, not even an ultrasound. In my practice, I generally use ultrasounds only for injections, so ultrasound guided injections. I very rarely use them for diagnostic purposes. Any questions so far? The silence is deafening. So,
hang on, Manish. I was fluffing about. I couldn't get my mute to. One of the doctors has just written tear of supraspinatus tendon. There's no specific question, just that. So I don't know if you want to talk on that at all, or whether or not you've just covered.
Well, I have, but so there is. Let me talk a little bit about rotator cuffs, because it seems a bit of a. It's not a difficult concept to understand, but this is all I do, right? I do shoulders and elbows. When you're in primary practice and you have to see everything that walks through the door, from chronic illness, medical disease, all sorts of surgical complaints, et cetera, mental health. Yeah, it's not easy to like be mindful of everything acutely, but it's a simple way to break down the rotator cuff. The rotator cuff is a group of tendons that come from the shoulder blade onto the ball of the shoulder, and their primary function is to hold the ball of the shoulder against the socket, because the ball of the shoulder is so much bigger than the small flat socket. It's like a golf ball on a golf tee. So you've got a group of tendons or muscles and tendons that basically brace the ball of the shoulder against the socket. There's one in front, there's one on top, and there's one at the back. So the one up front is subscapularis, which is the biggest of the rotator cuff and the least involved in tearing, either acute or degenerative. There's one on top, and there's one at the back. Supraspinatus on top, infraspinatus at the back. The reason supraspinatus tears the most is twofold. One, it passes through the really narrow subacromial space, so it's really being choked between the humeral head and the acromion. And two, the action of deltoid to try and lift the arm up really pulls the humeral head aggressively against the acromion, squashing that supraspinatus, which is already in a tight space. So you've got a tendon in a tight space, small tendon, and it's counteracting the superior pull of the deltoid by bracing the ball of the shoulder against the socket. That's the reason it's the most frequently torn. Now, I've already mentioned that sort of degenerative wear and tear, supraspinatus tendon tears don't need surgical treatment in the first instance. And the reason for that is if a physiotherapist can obtain good force coupling balance by training the subscapularis at the front and the infraspinatus at the back to work in tandem with an active deltoid, good useful function and resolution of pain can be achieved. But in a more acutely symptomatic supraspinatus tendon tear, where there's significant acute imbalance in the shoulder, that can lead to early degeneration of the shoulder, which is why in those acutely symptomatic younger people, we tend to want to fix them to restore the balance in the shoulder. I hope that answers the question. I'm happy to take follow-up questions.
There's a couple of other questions here along the way, Manish. How many cortisone injections recommend? And there's another one here. With cortisone injection likely to increase the risk of full thickness tear from partial thickness tear?
Yes, good questions. So I'll start with the first one. How many cortisone injections can you have? The short answer is there's no limit. The long answer is the risks of cortisone are cumulative with relationship to time. So if a person needs one injection every 3 months because they're not suitable for surgery, don't want surgery, and need something on a long-standing manner, you could probably inject their shoulder once every 3 months without any downside, and you could do that for years. But if a person has one injection and only lasts for 2 to 3 days, and the person needs one or comes to you saying, I need an injection every week, well, the cumulative dose of corticosteroid in that time period exceeds physiologic safety. So it's more about how many injections, how often. So if a person says to me, look, I don't really want surgery, every injection you send me for works for a couple of months and I'm happy to come back every 3 to 4 months for an injection, by all means, that's reasonable. But the other thing I say to patients is if you're needing regular injections, you might want to look at a more durable solution. That solution might not be repair of the tendons if you're older, if the tendons are chronically torn. That solution might be reverse shoulder replacement. And many of my colleagues out there that are listening to this talk, GPs, will know that a lot of the reverse shoulder replacements recover and rehabilitate much faster than rotator cuff repairs. Because you're not reliant on a biological thing to heal, you're putting in an implant that doesn't need the rotator cuff tendons to work. And here's another upside here. Don't ever order an ultrasound after a reverse shoulder replacement. It's going to show you torn tendons because they were already torn and they weren't repaired at the time of arthroplasty. A reverse shoulder replacement is put in to replace the function of the rotator cuff, not to fix the rotator cuff. So people freak out when someone orders an ultrasound after a reverse shoulder replacement saying, oh, the tendons are all torn. Yeah, they were all torn to begin with. That's why we did a reverse shoulder replacement and we didn't fix the tendons. The second question was, can a cortisone injection cause a partial thickness tear to become worse? The answer is yes, but one corticosteroid injection is unlikely to cause a partial thickness tear to become a full thickness surgical tear in isolation. I am happy with one injection in subacromial bursa to facilitate an appropriate rehabilitation program because it's hard to rehabilitate something that hurts. Having said that, my preference now is to actually not inject the subacromial bursa in the first instance where surgery may be an option because yes, corticosteroids have a deleterious effect on rotator cuff tendons. But in the first instance, I refer people for a suprascapular nerve block. It's not complicated. The radiologist will do this as simply as injecting the bursa. They'll do an ultrasound guided localization of the suprascapular nerve at the suprascapular notch and inject there. That basically reduces the pain sensation provided by the suprascapular nerve and also decreases the motor function of the rotator cuff a little bit, enough to facilitate recovery from the pain, restoration of motion. But primarily it's a sensory block, so decreases the pain sensation. So that's a really good question. My preference is a suprascapular nerve block rather than a subacromial injection in a partial thickness tear where I think surgery may be an option at some point, but subacromial injection is absolutely fine if performed once in isolation to facilitate rehabilitation. Are there any follow-ups on that one?
I'll just ask one more question and then you can go on to case 3. There are a couple of other questions.
Yeah.
Does complete immobilization help in acute cuff tear healing?
Oh, great question. So, I mean, it's hard to answer that question. I guess presumes that all full thickness rotator cuff repairs are the same, but they're not. There are some that are under, some that are more long-standing that are under a bit more tension after the repair. There are some that are acute that are under less tension at the time of repair. I guess the surgeon, if this is a post-repair question, if the surgeon determines that the repair was reasonably straightforward, not under a lot of tension, you know, the muscle quality was good, the tendon quality was good, the symptoms were acute, I prefer early motion. If on the other hand, the repair was under a bit of tension, it's a revision situation or a chronic situation, really long-standing, then yeah, we might prefer to immobilize even with one of those abduction pillow type slings. The vast majority of early repairs, if required, I mobilize at 2 to 3 weeks rather than, because prolonged immobilization will actually lead to stiffness, which can become a big problem to solve. Shall I move on?
Yeah, move on to the next case and we'll do these questions at the end otherwise.
Okay, perfect.
Yeah.
So 68-year-old lady presents to you with an 18-month history of pain in the right shoulder. Again, no history of injury. She has night pain. She has progressive loss of motion actively. So again, the history, you're not sure what the passive motion is. The active motion is reducing, there's night pain. You think this might be rotator cuff issue, but you need to really physically examine the patient. So you do. And you notice that not only is the active motion reduced, the patient can't lift their arm themselves, but passive motion is reduced. They complain of pain, and you can feel some crepitus in the shoulder when you lift the arm up. Within the confines of the physical examination possible, the strength seems okay. So normally I turn to the audience and say, what are your thoughts? Again, one of your colleagues who didn't sign up for this talk tonight has sent the patient for an ultrasound, which is what most people do in primary practice for shoulder complaints. And the ultrasound report says there's tendonitis of the supraspinatus, there's some bursal surface fraying and a partial tear, there's some bursitis. This may be amenable to an ultrasound guided injection, and clinical correlation is recommended. But you weren't to be fooled. You said, no, you need to go for an x-ray. Your active and passive motion is reduced. I need to differentiate whether this is arthritis. And bingo, your x-ray shows you what is essentially garden variety primary osteoarthritis of the shoulder, which isn't that rare. The key features here, there's loss of joint space between the humeral head and the glenoid, there's sclerosis of the joint surfaces, there's an osteophyte hanging at the lower end of the humeral head, which is commonly known as the goat's beard osteophyte for obvious reasons. The axillary view seen on the right shows significant loss of joint space. It shows there's posterior subluxation of the shoulder, which is most common in arthritis. So here you have a person whose active and passive motion is reduced. They're a little bit older, so it may still be frozen shoulder, but it might be arthritis, and your x-ray confirms arthritis. What to do now? Does this person need an operation just because they got arthritis in the shoulder? Well, always the answer to that question is, what are my goals of treatment? My goals of treatment are relief from pain, restoration of function. If you just ask yourself that, I need to get rid of their pain and restore their function, well, then you can think, well, what are pain relieving measures? They may be, that's just a busy slide that says what I've already said, reduction in range of motion, x-ray confirms it. So the goals of treatment are to relieve pain and restore function. Simple measures can always be first up. Anti-inflammatory tablets, analgesic tablets, injections for corticosteroid injections into the joint, not bursa, because this is a joint problem. So glenohumeral injections can be effective. Physiotherapy can be effective at restoring functional movement. Surgery can be a good option. And I'm hopefully a little bit better trained than Dr. Nick, although he's one of my favorite doctor characters, surgeon characters. But surgery can be a good option, but you're always, the goals of treatment, pain and function. Start with simple measures. Consider what the patient needs in terms of their lifestyle, plus or minus their occupation, and go from there. So the summary here is the diagnostic pillars of orthopedic assessment, and the shoulder and elbow are the same, is take a good history. You don't have to ask specific questions, just listen to your patient. They're telling you the diagnosis most of the time. They'll tell you where the pain is, and sort of impingement pain and cuff disease tends to be down the arm rather than in the so-called shoulder. Acromioclavicular joint pain tends to be on top of the shoulder. It may radiate down the arm or up into the neck. Be wary of neck pain, which can radiate from the neck across into the shoulder. And any pain around the medial aspect of the shoulder blade is actually cervical spine until proven otherwise, not primary shoulder. The second important pillar is examination. And there's another quote here. The first one was a quote, listen to your patient. The second one, this is not something I do, but it's a quote about the importance of physical examination. One finger in the throat and one in the rectum makes a good diagnostician. Examine your patient. And you saw the active and passive motion there on that slide. The same intelligent person and I'm going to ask towards the end of the talk, does anyone know who made these quotes? And it wasn't me. Investigations, the advice is sought to confirm a position already taken. In other words, don't ask for an ultrasound, certainly not an ultrasound, and even an X-ray, without knowing from your history and physical examination what you think the diagnosis is. It should merely be something, a tool to confirm your diagnosis, not to take the place of a good clinical assessment. And an X-ray should always be the first investigation in a musculoskeletal complaint. It doesn't matter what it is, whether it's a knee, a hip, a shoulder, an elbow, always get an X-ray. Like my erstwhile mentor has said, orthopedic physical examination is look, feel, move, X-ray. In isolation, without the benefit of a good physical exam and an X-ray, an ultrasound has a low diagnostic yield. It does have a use. I'm not saying eliminate ultrasound, but always think it's in itself not diagnostic, and don't let it replace your clinical assessment and an X-ray. The third learning point here is that radiologists are looking for their next meal ticket. So they will, and I'd say that with all due respect, radiologists will always recommend a reason for you to return the patient to them for another thing. You send them for an X-ray, they'll say, send them back for an injection. You send them for an ultrasound, they'll say, send them back for an injection. You send them for an X-ray, they'll say, send them back for a CT. What you'll note as GPs is they never ask you to send them back for an MRI scan because they know you can't. But they'll send that to me. So they're very clever, they're very cluey. But they will always send you a caveat, a warning. Clinical correlation is recommended. Heed that advice. Perform a history, do a physical exam, and if necessary, call your friendly orthopedic surgeon. I'm always happy to take a call, and I know good colleagues of mine are always happy to take a call. Run through the case, because sending a person for an injection which was unlikely to be of any use is not going to help them. They're not going to be happy. It's going to waste your time. There are other things you can do. That ends my shoulder aspect. It wasn't exhaustive, but it's illustrative. And I'm going to move on to a couple of elbow things because I thought in terms of time, I wouldn't be able to do long cases here. I thought I'd be a bit more didactic and just talk to the slides. But are there any questions about shoulder before I move on?
Yes. So reverse shoulder is not only for arthritis, but to replace rotator cuff tear?
Yes. So actually, when reverse shoulder, this is a whole new lovely talk I can give, but when reverse shoulder became successful in the 70s initially by a fellow named Paul Gramont in France, Lyon, it was actually indicated for an irreparable rotator cuff tear, which was symptomatic in older people. So yes, it was designed for irreparable cuff tears with or without arthritis, as long as it was significantly disabling rotator cuff tear. So yeah, if the rotator cuff can be repaired successfully, that's usually younger people, that should always be first protocol.
Okay, another question. Oh, go. Yep.
Just a quick follow-up. The whole reverse thing, flipping the polarity of the shoulder, putting the socket where the ball was, putting the ball where the socket was, replaces the function of the rotator cuff because this is inherently stable now. Like I said to you, the rotator cuff is designed to brace the big ball of the shoulder against a small socket. Here, we've got a socket up against the ball. It doesn't need anything to hold it in place. The deltoid can pull the arm around that socket wherever it wants. The French who designed this jokingly say, God got it wrong, we fixed it, but it's not quite right. But just to give you an idea, A, of French arrogance, and B, of the point of the reverse shoulder.
Okay, another question here, and bear with me. I think it was supposed to be, can we order supraclavian nerve block in every partial rotator cuff tears?
You can if they're symptomatic. I do. Okay. So if they come to me and they haven't had the benefit of any meaningful injections or treatment like that, in the first instance, I will refer them for a suprascapular nerve block, and the radiologists know what to do. So yeah, I will. Now, bear in mind, if that fails, you can follow up with a subacromial bursa injection. even within a few weeks. There's no contraindication to that. But then, yeah, you want to be wary of the third injection within a short time period.
Okay, and someone's just written MRI and X-rays, but I think you covered some of that. Did you want to talk any
So
further?
MRIs are not required for diagnosis almost of anything. So in my practice, I'll perform a good history and physical exam. I'll do an X-ray, and that will be enough to make the diagnosis. I will use MRI scans in surgical planning, A, to ensure the rotator cuff is repairable, and B, to precisely define the rotator cuff injury. Also, separately, MRI scans are useful in instability of the shoulder, which I've not covered here, but if someone has a dislocation, younger people, then yeah, MRI scans are useful in looking at deep inside the shoulder joint, the glenoid labrum, the superior labrum, and even the rotator cuff in the instance of instability. X-ray is always my first go-to, and I mostly use ultrasound for injections, as in I refer for ultrasound guided injections. And I have a few select radiologists whose ultrasound I trust, and I might ask them to look at ultrasounds post-op to check structural integrity, healing, etc.
All right, thanks, Manish. How about you move on to the next one?
So this is not cases. This is where I got didactic because I thought, we're running to the end and people are starting to get bored and whatever. But so the common elbow things I see, I get a lot of referrals for lateral epicondylitis, commonly known as tennis elbow. It is insidious. Well, it's not an inflammatory problem. It's a degenerative angiofibroblastic, which basically means normal, good quality type 1 collagen tendon is replaced with weak fibrous tissue and the ingrowth of blood vessels, which is A, not normal, and B, weakens the area. It tends to involve, well, in 100% of cases, it involves the extensor carpi radialis brevis, which is why wrist extension is painful. And in 25% of cases, it can involve the finger extensors, which is why finger extension can be painful. It can be associated with a number of conditions, and this is something it's always worth keeping in mind. Do they have medial epicondylitis, which is far more rare? Do they have ulnar nerve symptoms with cubital tunnel? Do they even have carpal tunnel symptoms? And do they have shoulder impingement or weakness or pain issues? And if they have a lot of these, then that's a mesenchymal syndrome type phenomenon. And that you should always ask about these things. And that mesenchymal syndrome will always need a good physio rehab program. But even tennis elbow will. So tennis elbow, they'll characteristically tell you that I had insidious onset of activity-related pain in the lateral aspect of the elbow. And it's called tennis elbow because it has an association with the backhand in tennis and the grip. But it's even been described in politicians who shake hands a lot. In this day and age of COVID, where we're bumping elbows or staying distant from people, I'm guessing a lot of tennis elbow is settling down. But even gripping for a handshake can provoke tennis elbow if it's done a lot. So it's an insidious onset of activity-related pain. And then when it becomes bad enough, the pain is even at rest, and they get functional impairment, weakness. I've been a victim of tennis elbow myself, and it kept me awake at night, and it was difficult operating for a while. So, I really had to modify my surgery to allow me to cope. The key here on physical, again, take a history. The patient tells you, I've got this pain on the outside of my elbow. I can't hold things. It started slowly, but now I can't even sleep at night. Okay, you've got a pretty good diagnosis. Your physical exam will show you that they're tended just in front of and just below the lateral epicondyle, not necessarily right on the lateral epicondyle, but where that tendon takes off, just below and just in front of the lateral epicondyle. You'll ask them to extend their wrist and hold the position, and you'll try to overcome it, and they will have significant pain again at that spot. Now, some things to note. If they've got pain through an elbow range of motion, flexion and extension of the elbow, that might mean there's some intra-articular problem, like arthritis inside the elbow. You always get an X-ray, and if the pain is a bit more distal in the forearm, it's more of a dull ache in the forearm, not necessarily right at that elbow, that might suggest something else. Again, always get an X-ray. The X-ray will show you any significant arthritis inside the elbow joint, and it'll also show you people who've got a chronic tendon issue with calcification or exostosis of the lateral epicondyle. And that X-ray change at the lateral epicondyle is a negative prognostic factor for non-operative treatment, but that doesn't mean you don't try non-operative treatment. Here's a list of things that good quality studies and reviews have shown to be effective. Good, use these. Diclofenac, Voltaren. Now, not all non-steroidals have been studied. For example, naproxen, naprogesic, has been shown to be no better than a placebo, but diclofenac, Voltaren has been shown to be effective. That doesn't mean you can't choose another anti-inflammatory, but be warned that failure of response to one anti-inflammatory doesn't mean another anti-inflammatory might not work. Now, the really cluey people out there who are listening to me are saying, well, you said at the first slide that it's not an inflammatory problem. Why are you prescribing an anti-inflammatory? Well, I'm glad you asked. The answer there is twofold. One, it works. But two, yes, the primary problem is an angiofibroblastic degeneration of the tendon, but it does provoke overlying inflammation. So inflammation in the skin and adipose tissue surrounding, and inflammation in the synovium of the elbow joint deep. So whilst it's a degenerative tendinopathy, it does provoke inflammation, which is why anti-inflammatories work. Physiotherapy works. Now, different modalities of physiotherapy, eccentric strengthening, isometric strengthening, concentric strengthening, all the evidence shows that it makes no difference. But the mere act of physiotherapy is better than doing nothing. And a good physiotherapist will concentrate on some of those other conditions I talked about, rotator cuff, cubital tunnel, carpal tunnel, and treat the patient as a whole rather than isolating on painful lateral elbow. Counterforce bracing, which is that tennis elbow strap, this is not something that needs to be applied firmly. The point here is proprioception. All of you are sitting there right now and you're not looking at your feet, but you know where your feet are because your proprioceptive nervous system is telling you that your feet are on the ground. Similarly, we don't need to always pay direct attention to where our muscles and joints are. We are aware of them through this proprioceptive feedback. Wearing a strap on your arm increases that neural proprioceptive feedback and prevents, so that way your body is primed to prevent injury. And that's how counterforce bracing or tennis elbow straps work. So they are effective for people to wear when they're doing activities that may cause them to injure themselves, which is even work or gardening. And they don't need to be applied tightly. I've put steroids for short-term relief of acute symptoms in brackets because for two reasons. One, they can be effective at short-term relief in acute symptoms, but longer-term studies have shown that people treated with steroids actually do worse than people treated with nothing, with supervised neglect. So in other words, if you've got someone who's acutely symptomatic, who can't sleep at night, and they're grabbing your collar saying, help me, yeah, a steroid might help at that time. But don't use them liberally in everyone, just very select few with acute symptoms. But PRP has been found to be effective, not only at reducing pain in the short term, by acting as an anti-inflammatory, but by promoting improved results in the longer term. Now, I alluded to my tennis elbow experience earlier, and I had one shot of PRP along with counterforce bracing and some physical therapy, which I did myself, and I recovered after a few months. PRP, yes, I accept that it's expensive. It's not necessarily easy to access. Whole blood injections can be as effective as PRP. PRP is just a lot more concentrated, so a lower dose can be used. It hurts like hell, I'll admit, when you have it done. I know from bitter experience. The first 6 to 8 hours hurt a lot. And the reason for that is because it stimulates an acute inflammation as a healing response. But it is effective and it's better than steroids. So use PRP.
Manish, someone's asked who gives the PRP, and another question: how are tennis elbow and golfer's elbow similar or different, including treatment and epidemiology?
Okay, they're the same. One's lateral epicondylitis on the extensor side of the elbow, the lateral side. One's medial epicondylitis, flexor side, medial side of the elbow. It's just that medial epicondylitis, golf elbow, has about 20, not even 20% the same incidence as lateral epicondylitis. It's far less common, which is everything I'm saying here is applicable also to medial epicondylitis. PRP, how accessible is it? It's actually getting more and more accessible. Once upon a time, only certain doctors were doing it, but now most radiology many radiology practices are doing it too. So talk to your local radiology practice and see if they're offering it. Otherwise, there are a number of very good sports physicians around who are offering it. So I tend to work closely with both radiologists, despite the fact that I was paying out on them earlier. I do work very closely with radiologists and sports physicians. So it is readily accessible. Find your local sports physician, find your local radiologist and have a chat saying, are you doing PRP? What's the cost, etc. It does cost a couple of $100. I don't know why it costs a couple of $100, to be honest, because it takes 10 minutes to centrifuge the blood in a centrifuge. Then you pipette out the supernatant, which is the plasma and platelets in the top layer. It's not rocket science. All you need is centrifuge. So maybe they're just recovering the cost of the centrifuge.
Is it Medicare covered?
Nope. And that's why a lot of people don't want to pay for it. So it's not. It should be, but it's not. And steroids are. But so, but don't, it's our job to educate our patients. Yes, a steroid is covered, hence it won't cost you much or at all, where PRP is not covered, and it will cost you $200 to $300 depending on who you go to. But steroids, it's our job to tell our patients, steroids in the longer term will be worse than doing nothing. So if you don't want to pay for the PRP and you can tolerate the pain, then doing nothing will lead to 70% good results anyway at 6 months. So I would reserve the steroids, despite the fact that they're covered by Medicare, only for the acutely symptomatic people who are just ready to smack you if you don't do something for them. But for everyone else, our job is to educate people saying, look, PRP will help this to heal better than doing nothing, better than physio. Steroids may help for short-term relief, but they're going to be worse than doing nothing in the long term. That's the answer to that question.
Okay, just a couple more. Extracorporeal shockwave for tennis elbow, how effective is it?
It's not, and I'll come back to it.
All right. And how long does it take to get the full effect after PRP? And how is it worse?
How's it worse?
I thought that
How
was
does it
all.
work?
Oh, could be. How is it worse? Could be how does it work? Let's ignore that one.
I think I've answered why it's acutely painful after about 6 to 8 hours, because it stimulates an acute inflammation. How it works is because the platelets contain all the growth factors. So the way I simplistically tell patients is our blood has red blood cells, which is our oxygen for energy, white blood cells, which is our immune system, and platelets, which are not only clotting, but all our healing and growth factors. So platelets are little balls of granules. When they degranulate, they put out a whole bunch of healing factors, platelet-derived growth factor, fibroblast growth factor, blah, 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 all this stuff that we learnt in physiology and biochemistry. So this concentrates growth factors. The idea is tendons, all tendons in the body have a poor blood supply and a poor access to growth factors, which is why they tear. The Achilles tendon, the tennis elbow tendons, the medial golfer's elbow tendons, the rotator cuff, etc. So platelets, if we inject platelets, that delivers good growth factors at the growth factor starved tendons, and then in terms of cytokinesis, chemokinesis stimulates a healing response. So that's how they work. How many can you have? How long does it take to have effect? I don't know if anyone watched me, but I'm saying bye to my family. How long does it work? It's difficult to predict. There's no sort of definitive timeline. Usually I tell people to give it at least 2 to 3 weeks for the first injection, and you can follow up. If you go to a sports physician, most of them will tell you you can have 3 injections, and they usually space them out somewhere between 2 to 4 weeks per injection, depending upon the response. Beyond 3 injections, I tend to think, well, it's probably not going to be enough, and we should look at another solution. So that's the answer to that question. I had one. I gave it, along with counterforce bracing and some exercise, I gave it 3 months, and I got better. Prolotherapy. Prolotherapy is the injection. Prolotherapy is short for proliferative therapy, and it's the injection of hypertonic sugar or saline to try and stimulate proliferation. And that has been shown in good meta-analyses and randomized control trials to be better than placebo at effectiveness in this. So prolotherapy, again, is not covered by Medicare, but it might be cheaper than PRP, so it's worth thinking about. And then surgery does have a role, and I see probably 100 tennis elbow referrals every year, maybe more. I probably operate on 5 or 6. So in other words, surgery is never your first go-to. There's always things you can do first. These are those things you can do first, and give it 6 months. Questions there?
Just one more. I'm just conscious of the time. How is cortisone worse in the long term?
So someone asked me a question earlier, does cortisone weaken the tendon? That's why it's worse in the long term. It weakens the tendon. It causes tendon degeneration, more tendon tearing. And because this structure is quite subcutaneous, it can cause skin changes, skin atrophy, fat necrosis in that area. So that's why it's worse. These things I've crossed out. There was a question about extracorporeal shockwave therapy. There have been no good studies that show it's better than placebo. Not randomized control trials, no meta-analysis, no reviews have shown them to be better than nothing. So it's a waste of time. Similarly, ultrasound, waste of time. Botox kind of made sense. You know, you paralyze the muscle, give the tendon time to heal. But again, it's expensive. It weakens grip because it paralyzes the muscle, and it hasn't been shown to be more effective than placebo in follow-up. And the other thing that I commonly get asked about, which is why I had a look, is nitrate patches to deliver nitric oxide to the area to stimulate angiogenesis and proliferation. Again, no good studies have shown it to be effective. So these are things I would cross out of my list. I'll just quickly race through this because time. So I see a lot of elbow stiffness. People think, well, elbow stiffness is not that common. You can't do anything about it. Live with it. See you later. But it's actually common. It's not necessarily post-traumatic when in terms of significant fracture or injury. It may be just overload or repetitive microtrauma. There may be a history of osteochondritis dissecans, which is flaking of the cartilage of the capitellum, which exposes the capitellar bone and causes radiocapitellar arthritis. That's not necessary, but there may be a history of adolescent lateral elbow pain. There may be a subclinical instability because of overuse. The ligaments have been stretched out. You get some micromotion, which is incongruent. There is a lot of force that goes across the elbow, and this overload and repetitive microtrauma may lead to primary osteoarthritis. An X-ray might be as benign as the one on the left, and you might look at it and think, well, that looks all right. But no, even to the astute eye, at the anterior aspect of the humerus, just near the radial head, you can see an osteophyte, which will cause impingement of that elbow. On the right-hand side, the scans are a bit more clear, and this is not a normal looking x-ray, this is arthritis. Again, history. They're going to tell you they got pain. They might have pain only at end range. Oh, look, doc, I can't straighten my arm beyond this point and it hurts when I try, or I can't bend it more than this point and it hurts when I try, or I can't move my arm much at all without it hurting. The key here is to determine the range of motion. If the range of motion is functional, in other words, they can do what they need to do, then you might want to treat them simply with some physiotherapy, try and stretch the joint as much as mechanically possible, some injections, some anti-inflammatory tablets, etc., the usual things that we've talked about. If their range of motion is severely limited from a functional point of view, either activities of daily living and work, that may not be enough. It's still worth trying splinting and physiotherapy, but we may have to start to think, well, there may be something to this. This CT shows advanced arthritis with lots of spurs, lots of joint space. You can see all that doesn't look normal. It looks like the surface of the moon in there. So there are lots of good options. So don't think your patients aren't amenable. There is an incidence of elbow stiffness. It may not necessarily be traumatic. It may be just repetitive microtrauma or high loads, work, sport, occupational, whatever. There are lots of options. I do a lot of arthroscopic cleanouts for arthritis. I do joint replacements for arthritis, mainly for older, lower demand people, or you can do open surgery. But that's, yeah, this is kind of cool. Just a couple of minutes here. I think that's kind of the end of my talk anyway, so it's open to questions now while you watch that video.
Yeah, so look, I'll just thank you very much for your time tonight, Manish. Really appreciate that. So just, I'll do a bit of a summary and then there's a couple more questions, so whoever wants to hang on can. Don't forget, for your evaluation, you need to click on that SurveyMonkey link. We do have another Zoom virtual education session on oral contraceptive pill on the 16th of June. So there's a couple of spaces there, but if you miss out, just send me an email. So thank you, Manish. We appreciate your time. And we have another question. A couple of them have asked whether or not you're happy for us to send the slides over, Manish. Is that okay?
Yeah, 100%.
Great, excellent. One of the doctors wants to know stem cells. How does it, your thoughts on stem cells?
I think stem cells is an evolving concept, and it does have a future, but current in practice, it doesn't have a role. Even the College of Sports Physicians, College of Sports Medicine has labeled its use experimental. Again, there are no good studies showing any usefulness in any field. It will lighten the wallet of your patient by $8,000 or more, but even the College of Sports Medicine is saying it can only be labeled as experimental. That's not to say it doesn't have a future. I'm sure orthobiologics, stem cells, gene therapy is the future of a lot of stuff, but in today's current practice, I can't recommend it for any orthopedic condition.
Okay, and then the answer to your question was you wanted to know if any of the clever doctors out there knew who said advice is sought. And Dr. Shankar said Sir William Osler.
Oh, mate, he got it. This slide right now is telling you.
If he was here, we would, I wasn't even looking at that.
Yeah, so William Osler, who was not even a surgeon, who was the father of the medical training program, one of the founders of Johns Hopkins Hospitals, which is in the news because they've got the Corona countdown going on there. But he's full of good quotes. And one of his great quotes here is, the good physician treats the disease, the great physician treats the patient who has the disease. Don't forget, behind the problem, there's a person, lifestyle, needs, occupation, someone who tells you a history, who has a physical exam, and then we work on it.
Fantastic. All right, Manish, we really appreciate your time. I did send Manish's bio out to you a couple of days ago. He does have rooms at Castle Hill, Bella Vista and Penrith, and is always very approachable. So don't hesitate to get in contact with him if you have any questions.
Happy to hear from anyone, anytime.
Yeah. So enjoy the night. If you're going to watch the footy, enjoy. If you're going to have dinner, enjoy. We'll see you at our next virtual GP education. All the best. Good night. Thanks, Manish.
Thanks. Bye.
Bye. We hope you have enjoyed this GP education program with Dr. Manish Gupta. To gain your CPD points, please complete our evaluation via SurveyMonkey using the QR code on the following page or the link provided. We hope you can join us for more of our GP education in the coming weeks. Thank you.